for a number of years, our association has been advocating for and doing research on and focusing in on this topic of residential care facilities and residential care facilities for the elderly, specifically for people with serious mental illness who need that level of care and housing, whether it's short term or long term. And Ed Ortiz actually served on one of the local boards in Napa County. And he, along with Kerry Landry, are going to present a paper that they have put together for the California Healthcare Foundation. It's called Assisted Living, a community-based housing option for people with behavioral health needs. So I'm so pleased to introduce Ed and Kerry, and I'll let you share your screen if you want to, Ed, and you're welcome to introduce yourself as well.
Thank you.
Great. Thanks, everybody. Thanks so much for having us. Let me just get our slides pulled up here, and we will jump right in. All righty. So my name's Kerry Landry. I am an independent consultant that has been working with Ed for quite a while on behavioral health and Medi-Cal. The last few years, my work has spanned state and county agencies, community-based providers, and projects through foundations like the California Healthcare Foundation. A lot of cross-sector work and a lot related to CalAIM, which was a lot of transformation of our Medi-Cal program here in the state. My background is Medi-Cal managed care. I did some time at a health plan based in the Bay Area, and then I was also an assistant deputy at our state Medicaid agency. Ed, would you like to introduce yourself?
I would indeed. Well, it is really my pleasure to be here today to give this presentation and to have some dialogue with this group on this topic. It's a very important topic to me. You know, as a former Napa County Mental Health Board member from a few years ago, who now lives in Hollywood, I do a lot of work in the behavioral health space, and I do it as a consultant, but I also work in behavioral health as an advisor to a clubhouse locally called Fountain House, which is shown on the slide. And I work with another organization called Hollywood Forward, where I sit on the board. And this is a coalition of over 50 different community-based organizations who are focused on addressing homelessness and individuals who have severe mental illness. So this topic is extremely important to me. I think it's an opportunity for us to fill some gaps in the continuum of care that currently exist. And I can't thank Teresa and the association here for really focusing on this question. So thanks for inviting us, and I'll turn it back to Kerry.
Great. And before I move on, just to let everybody know, I know we've got quite a few people on the line. Ed and I are going to try to take your questions as we go. So as you have questions, please put them in the chat. And we'll try to make sure if there's any gaps in, clarification, want to make sure everybody's following along as we get through the content. So please keep your questions, and we'll try to make sure we pause as we go so things get answered. Alrighty. So this project evolved from some prior work that Ed and I did at the foundation, where we worked to develop a more generalized behavioral health treatment beds and housing continuum. As I'm sure you guys are really closely aware, acutely aware. This is some complex stuff, especially when we're looking at treatment and housing and how we really want to make sure people are in the right level of care. There's lots of different payers and players and providers and systems to keep track of. And so what we had experienced on that initial project was a lot of not even confusion, but a lot of people with questions about how assisted living facilities worked and really thinking through them only through their view, which might not be the entire system of care. And so we set out on this project to increase the understanding. So we had heard from folks bits and pieces, and we were like, we need to bring the bits and pieces together, especially for folks like yourselves who really want to look at the whole picture and the whole system to really best serve residents. We wanted to make sure everybody was clear on like what we mean when we say assisted living. You know, in California, or adult residential facilities or ARFs, and residential care facilities for the elderly and RCFEs, and really focus and hone in on those. We had heard a lot from the ground about challenges. So, you know, our conversations with Teresa about facilities really struggling and needing to close, capacity not meeting the needs of residents. But then we were also hearing there were vacant beds. There were vacant beds places. And so Ed and I were like, we got to figure out what's going on, and where is the complexity getting the better of us. Where we're missing some of those like key pieces to really get people matched up at the right level of care. We talked to a lot of different communities and really wanted to come up with some ideas about how we resolve that. So the first thing was like, this project, we want to increase the understanding, put all the bits and pieces on the map, try to figure out where those real challenges exist, and then provide some recommendations. You do have the link to the issue brief, and when I pass this over to Ed, I'll put the links in the chat too, so that you guys can go directly to the issue brief. This one is the new one, and then the next slide we're going to move on to will be the first explainer on the continuums that we did for CHCF, and I'll also put that link in the chat. Ed, is there anything else you want to add on just the goals we had as we set out on the on this journey?
No, I think you got it. Thank you.
All righty. So as I had mentioned before, our initial work was to put bits and pieces on the map and map out the system. And so what you're seeing here is the mental health continuum and the substance use disorder continuums that were part of this first explainer. And again, the link's on the bottom. I'll put that in the chat in just a second. We did map all the way from acute settings, or you'll see here on the farthest to the left, forensic and correctional settings, all the way to more permanent housing settings, interim housing with supports. And a lot of the impetus for these continuums was because there were a lot of different funding sources, and we wanted to map where all of those programs coming out from the state, where really is that money going, and where on the continuum is it helping to support what levels of care. For this particular project, we wanted to clarify and make sure people knew where assisted living falls, and that it's not just interim settings, it's not just permanent settings, that it does span what we have on the continuum as community and residential treatment, interim housing, and housing with supports level of care. And so it appears on multiple levels of care. It's not just really like a narrow band. And I guess the only other thing I would want to mention on this is the goal with the continuums is we want to not have any backups and backlogs, right? So you want capacity to exist all along the continuum so that people can be at the right level of care and not get stuck at a level of care that's not appropriate, right? We want people to be in community-based settings. We want them to be supported for the needs that they have. And the highlight with this work was to show how assisted living facilities can really support people at multiple levels of care, depending on the types of services that are available there. We do have, when I say like levels of care, right, and we want there to be flow, the caveat to that is the forensic and corrections, um, categories on this continuum. When we talk to people, we did have a lot of confirmation that unfortunately that is part of the continuum right now. We have people who are living um, in correctional facilities with behavioral health needs because of the continuum not having the capacity where it needs to be, and people unfortunately being incarcerated. For the purposes of this project, right, and where we really want a flow on the continuum, we would hope that that would never be a level of care for people with behavioral health needs, and there would be other beds and housing on the continuum where they would be able to get the right level of care. But either way, like this is the reality that we live in. And we did hear from a lot of our state experts that unfortunately, like it needs to be on there because the goal is to really see it as the big picture and like where we have gaps and where we can fill those gaps. So yeah, so ARFs and RCFEs, multiple places on the continuum. And Ed, I will hand it to you to get into the details on ARFs and RCFEs.
Yes, thank you, Kerry, for sharing the big picture about ARFs and RCFEs and how they fit into the treatment bed and housing continuum. And I think, a lot of how I message the next slides are going to be more around how a board member or commissioner might consider them in the context of working with your behavioral health plan. So if you have additional questions about how I'm characterizing things, we can be more specific or more technical. But I'm really hoping to use this information to offer some informed engagement with your behavioral health plans when you meet with them and talk about things like systems of care and budgets. So the slide that you see before you is really just a general frame of what an ARF and an RCFE is, and I'll take you through that in a second. But I think just to give you a roadmap of where we're going with all this, we're gonna go a little bit more deeper into the continuum by sharing what an ARF and RCFE is. Many of you already know what they are, so we'll be sort of light in terms of detail on this. And then we'll talk a little bit about who gets served with these services with this type of placement. And then we'll talk a little bit about how these ARFs and RCFEs fit in the context of a number of different delivery systems, and to show you how they get used in very generic ways. But you'll see the range of different programming across the state that uses these services. And then we'll talk a little bit more directly about how a behavioral health plan might leverage these services, and we'll get a little bit more specific about where the opportunities are for board members and commissioners like yourselves to really maybe go a little bit deeper in understanding what the direction of the behavioral health plan is, or the behavioral health plan in using these assets, and give you some information about how to engage a little bit more with the plan on this topic. The last thing I'll say about this is we will share challenges and opportunities, time permitting, and I think we wanted to leave a little time for some dialogue with you all. We can share examples of how these resources show up in your communities, or questions you might have about how to leverage these services in the context of a behavioral health plan. Last thing I'll do is give you the context for sort of how many beds exist in the community. So, well, in the state, I should say. So there's about 250,000 ARF and RCFE beds in California. It's about 14,000 facilities statewide. And there's about 6,400 ARFs, which account for about 43,000 beds, and about 7,700 RCFEs, and that's about 210,000 beds. So there's a lot of beds. There's a lot of capacity in the community. Some of it is, overstretched, and in some parts of the state, there are a lot of vacancies, underutilization. So basically the difference between the ARF and the RCFE is really the adult residential facility is really targeted for people aged 18 to 59. And a lot of the residents in those facilities have behavioral health conditions. They need support with functioning. There's some developmental challenges with some of the residents. Many of the residents need social supports. The ARFs are really a great community-based resource that are non-medical. The goal is really to try to make these facilities home-like, less facility-like, and generally that is the case. The average size of the ARF is really much smaller than the RCFE. It's not uncommon for these facilities to be 4 to 6 beds, these homes facilities to be 4 to 6 beds in size. And many counties use these facilities to support behavioral health needs of people who need structure, support, 24/7 care, support with recovery. So this is one part of the definition of assisted living, and the other is really the residential care facilities for the elderly, which is targeted at people aged 60 and above. Again, focusing on community-like settings, although these facilities can be much larger in size, ranging from, a few beds to hundreds of beds. And the goal in these facilities, started out being different, where it's focused on aging in place and supportive services. But over the years, the acuity level has grown in these facilities, and there are more people in these facilities who have higher needs. They're higher acuity people. Both of these facility types are licensed by the California Department of Social Services. And a lot of this information is available online. We can share this with you as well. But this is sort of what is an ARF and an RCFE. If you go to the next slide, we can talk a little bit about sort of what services are provided in the ARF and RCFE. And I think it's important to kind of, as we think about these services, take a step back and think about how important this level of service is in a community where the options can be institutional options, if not but for a level of care, a level of support like this in a community. But the services are generally 24/7 supervised services. These are non-medical. They're not licensed to provide medical services. They do provide assistance with activities of daily living. You see them listed on the slide. Eating, dressing, bathing. I won't read them all to you, but they're organized to provide those services and instrumental activities of daily living. And for the population of people that we're focusing on in this conversation, those who have behavioral health needs, it is really a lot about coordinating with their care team. It's about supporting medication management. It's about really creating a situation where the resident has an ability to thrive in a community setting with supports. So these are sort of the services that are provided. And I do want to reinforce what Teresa was saying earlier in the conversation. California Behavioral Health Boards and Commissions has really been advocating that we keep these types of services in the community in a way that allows them to thrive and sustain themselves. Reimbursement and closures have been challenges for operators who provide these services, but these are really good resources for people who have behavioral health conditions. I think the last thing to just keep in mind as we think about these providers is that these facilities are already sort of there. There's 14,000 of them, 250,000 beds. They're already staffed. They're already licensed. We're doing a lot of things in our state to try to create more capacity for people to have community-based placement. And these exist. And as I was mentioning, in many communities, there's vacant capacity ready to be utilized. In LA, for example, the Future organization did a study. This is an organization that really went deep into the situation in LA County. How many beds are there? How many are participating in the safety net and in Medi-Cal, and what kind of vacancy is out there in these beds. And they identified almost 6,500 vacant or underutilized beds in Los Angeles County, in a place where we are, really in need of this type of level of care. And so I bring that up because we're going to talk about this concept a little bit more of the administrative complexity of actually these facilities connecting with people who have needs. But I just wanted to set the table with that. Kerry, we could advance to the next slide to talk.
There's a question in the chat that kind of relates to this. So Linda has a question. Do most RCFEs accept consumers with neurocognitive conditions and behavioral health concerns?
There are many that do. I mean, I can't be conclusive about this, and I'm not a clinician when speaking of neurocognitive, but there are a lot of RCFEs that will really extend the work that they do to serve people who have more acute specialized needs by supporting them with outside providers to the extent that they can through their license. And with behavioral health concerns, absolutely. I see that in a lot of facilities. And it's not easy. The continuum of these sort of treatment beds all the way to interim and permanent housing, they're all being sort of stressed with the same type of need to provide behavioral health services and supports in a setting that many times wasn't really intended for that. We see that a lot in interim and permanent supportive housing settings.
We have a question in the room too.
Yeah, hi. Thank you very much. So is of the 14,000 beds, did you by any chance summarize them by county, by type? So that's just yes or no. And then the second is how many of the 65% were the vacancy rate in LA is due to not accepting Medi-Cal?
Yeah, so that's a good question. I can answer both. So there are 14,000 facilities, which create 250,000 beds approximately. And I took the number from the, on the licensing, the California Department of Social Services licensing website, they offer this spreadsheet. You could go there now and grab the spreadsheet, and it would give you the count for both ARFs and RCFEs by county, by facility, by beds, and you'd see specifically how many. So I would recommend.
Hold on, because I've been to that site, so
Yep.
I just want to double check. So I've downloaded the 4,000 lines before.
Yeah.
So it may be a different spreadsheet. So I'm just asking, are they already summarized by county?
No.
Because what I did was I pulled out, and our county has enhanced boarding cares. And one of the reasons there's vacancy in them is it's a blended rate off beyond SSI, but the facility gets to determine who they're willing to accept relative to keeping the culture of the facility intact. So anyway, I just want to slow you down so you just, but if it's already county level data, if you just say yes to that, I'll go look it up.
Yes.
Okay, great.
And the other number that I wanted to sort of clarify is the 6,500 beds that were vacant or underutilized in Los Angeles County. So those beds represent beds that were identified through the Future Organizations study. And those beds were beds that were part of the safety net or Medi-Cal. So that means basically they were beds that the owners identified as participating in a county health or county housing program or in Medi-Cal. They only represented those vacant beds represented facilities that only account for 25% of the total amount of facilities in LA County, which means that 75% of facilities in Los Angeles County do not participate in the safety net or Medi-Cal. And so of those 25% that do, there was 6,500, almost 6,500 vacant or underutilized beds. And I have had the experience of going to probably 20 or so facilities over the last few months to see it for myself, what they look like. And I think some of what this last question that came up reminded me of is the selection process, the assessment process does drive in some ways whether somebody is a good fit for a facility. For example, when the facility actually does their assessment of the individual, they may uncover more things than were presented to them in the documentation that was used to determine whether if it was a good placement fit or not, either by the county or some other entity. And many times operators will say we get incomplete information or it doesn't match what the payer, the person who's placing the person has indicated. So I think there is not only there's a concern that they're not getting all the information, but then also a concern what happens after they accept a placement and the services that may not be available once that placement happens. Are there other questions, Kerry?
There are other questions. There's two more in the chat. So Maria has a question. She says, I was talking with the provider about Title 22 regulations in anticipation of accepting several clients in the ARF, of which some were jail residents, and wanted to know what intake information she needed to make a thorough assessment before accepting these clients. There seems to be a level of resistance and caution in accepting clients with forensic and incarceration history due to potential threats. Are you seeing this in ARFs and RCFEs? And if yes, how are you handling this fear and stigma?
Yeah, I mean, I see it regularly in Los Angeles. I've been to a few ARFs that are, really organized around the forensic, the justice-involved population. And so I know that in Los Angeles County, the Office of Diversion and Reentry, which is a county program, really organizes themselves around trying to figure out if they could master lease sites for this purpose. But I've been to many operators who are willing to accept people who have justice involvement. It's just, I think it is operator level type of concern that you would have to get through. The other thing that I find across the board, especially for complex populations, is that many times an operator will accept a more difficult, as they identify a more difficult placement if they know they have a partner on the other end who can support that placement long term and who can help them with the person's care plan and the person's, whatever their goals are. If they have that partnership, they're much more willing to take the placement. I've seen that in many facilities.
And one more question before we move on. Are RCFEs locked or unlocked facilities if they are considered community living? Wondering if people with with cognitive conditions, if they would need to be locked for safety reasons for someone with advanced dementia, for instance.
I mean, they're unlocked facilities. In general, there are some, and I can't recall exactly the designation of this type, but there are some that have delayed egress, but they for the most part are locked. I went to one a couple of weeks ago in Boyle Heights, and it was sort of a not not a delayed egress, but it was the doorways were also where the counter was, a reception counter. It felt like you were going to have to pass through staff to enter and leave, but the doors themselves were not locked.
All right.
All
Next
right.
slide.
Yep.
Great.
So I just wanted to share as you're thinking about the the desire for the behavioral health plans to use ARFs and RCFEs as part of their continuum to support people in community settings. There's a lot of competition for the beds, although it's very fragmented. So, the managed care plans, for example, have the ability to provide placement in assisted living, and they actually have the ability to pay for assessments and transitions from a higher level of care to a lower level of care to these facilities, and they have the ability to pay ongoing for assisted living services. So many times the managed care plans are really focusing on the physical health portion of somebody's care needs, but they are not you know they are not to exclude those who have behavioral health conditions, and so that might be what they're focusing on, but they are really required to really address the whole person's needs, and if they meet criteria, then these services through the managed care plans are eligible for this population. And of course, we know counties use ARFs and RCFEs quite a bit. They use them with full service partnerships. They use them in enriched residential care. Sometimes these words are used to acknowledge a financial patch of some amount. And some county behavioral health plans have enriched residential services, which is a bit more than just a financial patch. It is a more comprehensive suite of services. The counties use them to step people down from higher levels of care, from acute psych, from IMDs. They can be long-term community living resources. Our housing systems also use ARFs and RCFEs. They don't call them permanent housing, although many people who reside in some of these facilities, these homes, live there for many years. But the HUD doesn't refer to them as permanent supportive. They're interim housing, and they can be really good resources for people, especially in urban area. Well, I shouldn't say urban areas. In areas where there's a lot of need for people who have chronic homelessness and behavioral health needs, where you can create capacity to support people, to prepare them for permanent supportive housing, or help people when permanent supportive housing isn't the right fit for them to transition to this level of care. We also see a lot in the justice and reentry population using these beds. And I mentioned to you in Los Angeles, the Office of Diversion and Reentry does a lot to organize care around ARFs and RCFEs, and they do it to support people exiting jails and reducing recidivism and really creating a safe placement for people who would otherwise not be housed upon reentry. Skilled nursing facilities and long-term care facilities leverage these resources a lot as a step down, and our aging and disability programs, cities and counties use these programs, as well as hospitals and health delivery systems. There's a significant uh, utilization of these services. The challenge that we see in what you think about the operators is, if you're an operator and you're basically a small business, somebody who has a 6-bed home, or even if you're an operator and you have a 100-bed home, to participate in all of these delivery systems is a big undertaking. You really have to sort of have multiple contracts for different delivery systems, and it becomes almost overly burdensome to really participate past one or two of these types of systems. So we could probably go to the next slide and
There's a
um,
quick question
oh,
that I think you can kind of highlight. So Linda asked, is reimbursement to the provider based on the acuity of the consumer? Is it a tiered payment system?
yeah, it depends. It depends on what delivery system is reimbursing you. So the managed care plans many times use a um, a reimbursement model like the assisted living waiver, which has a 5-tiered system, and so managed care uses that a lot. Some county behavioral health plans either offer a flat patch, and some offer a more graduated level of acuity. The ones that I've seen more recently, county anyhow, that have different acuity levels, usually don't um, meet what the assisted living waiver or the managed care plans are offering. Homeless services, I think there's in certain continuums of care, they likely offer different reimbursement based on different levels of care. And I know Justice and Reentry does. Whether a hospital or a skilled nursing facility do or not to kind of cause step down, I'm not really sure. And aging and disability, I've seen places offer acuity, different reimbursement by acuity, but it's all over the place. And um, many times when the safety net itself is offering the reimbursement, it creates sometimes a scenario where the reimbursement doesn't satisfy the actual cost for the service itself. Sometimes the patch, for example, isn't enough. It may be enough to cause a placement, and if there's extra capacity, an operator may take the reimbursement, but sometimes it's just not enough. Um, so that's kind of what I've seen. And I think maybe I'll just focus on a few of the sort of program examples where ARFs and RCFEs are included in behavioral health plan types of activities. I mean, one I'll point out to you, and this is sort of the the oddity of this whole thing is we have a program in California through the Department of Healthcare Services. It's called the Assisted Living Waiver. It's been around for quite some time at this point, and right now it has an enrollment of just under 15,000, but a wait list of over 20,000. That's of February, I think, of this year. But it shows you that there is demand for the services. It's just been really challenging to match demand with the right payer within the system. Um, so that's one I'll talk through. Another one that I'll talk through is really the Behavioral Health Services Act. And this is one where it does include these, full service partnerships that can be used to sort of be an anchor for somebody's care needs where there's a need for structure and care at the level of an adult residential facility or an RCFE. Full service partnerships use these facilities quite a bit. And they are an effective part of what these programs offer. And I think I mentioned the enriched residential care and enriched residential services. The Behavioral Services Act has been great at the way that it has evolved from the Mental Health Services Act and the proportion of funding that is dedicated to housing and dedicated to homelessness and also dedicated to an array of services. So I think, as you think about and work with your own behavioral health plans about things that they're doing, it's really important to kind of think through not only can you make placement options available for people in your community, but it's also kind of important to recognize that, as Kerry was talking about in her earlier slide, this whole continuum, we really want to support people being at their appropriate level. And a lot of times what we see, um, what I'm noticing a lot is that people are getting stuck at higher levels of care, or they're not able to access a lower level of care in the community. And so they're put into, a higher level of care that they may not need. And I really think we see this in jails, and we see this in acute psych situations where people could accept a lower level of care. And conversely, we see this where people are at risk or rising risk, and they need structure, stability, support. BHSA can be an amazing vehicle to make those connections and really support somebody flowing down from higher levels of care and avoiding higher levels of care in a community setting. So that is one thing to really think about as your behavioral health plans are talking about what they're doing with Behavioral Health Services Act. And then, of course, BH Connect, which is a newer waiver. It's focused on a whole range of opportunities to provide community-based care and treatment. ARFs and RCFEs can be a great companion to the things that BH Connect is envisioning, from supporting evidence-based practices. So these are things like assertive community treatment. These types of programs, these practices are built around, in many cases, full service partnerships. But they create a mechanism, a developed support mechanism that can be a good companion to ARFs and RCFEs. And then you have things within BH Connect like this IMD incentive, and these IMD is Institute for Mental Disease. And currently, the state doesn't get federal reimbursement for these services. But if your county opts in for this, and there's a whole bunch of things your county will have to do, they'll have to decide if it makes sense for them. But if they opt in, they can be incentivized for providing community-based services by having federal financial participation for IMD stays. And IMD stays are basically, it's defined in the policy, but they're basically for, mental health, acute and like stays in facilities that have more than 16 beds. It's a tremendous opportunity, though, for a county to contemplate, and being able to connect into a resource like an ARF or an RCFE is a great opportunity. So these are some ways that these services show up in the continuums that are so important for behavioral health plans, but they're also important for board members and commissioners to sort of understand, so that the engagement with the county is informed. And when they talk about their planning, they can talk about it in the context of the composition of the resources in the continuum. And I hope that this will inform your ability to ask questions about, how are we organizing our continuum? What is the needed capacity, and how might we be thinking about beds that are needed, and promoting sort of more community-based living. So let me stop there. Do we have any questions on this slide?
Not on the chat.
Okay. Okay.
Wanted to clarify. So with the IMDs, there's a limit in terms of the number of people that can stay there. With the ARCs and RCFEs, there's no limit, right?
No. No. It's just a really good step down mechanism for people who are trapped at high, I say trapped, but people who are at higher levels of care who could benefit from a lower level of care. So that incentive will be a really, really good mechanism to support those transitions.
Right. And IMD, for those that don't know, is Institute for Mental is wait,
Is it-
Institution for Mental Disease,
Yeah.
right? Okay.
Yeah.
And those are locked generally, right?
Yeah. Yeah.
But with BH Connect, counties can opt in for, is it 30 days or 60 days where they can actually collect Medi-Cal for those?
Yeah. I can't remember if it's 30 or 60, but it is it's an attractive incentive for the counties.
Right. It's a way to pay for people because people from the counties are staying there. And in the past, it was all county, like BHSA or other areas of their budget going, a lot of money going toward that. But if they're able to opt in, and they have to show that they're building out community supports. So that would include the ARFs and RCFEs.
Yes, yes. Thank you.
Is this
I'm sorry, you cut out.
waivers?
Okay, go ahead.
Oh, I'm sorry. Assisted living waivers? I heard they stopped giving those out. Do they have a budget?
They 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 haven't stopped giving them out, but they have a enrollment cap per year, and they also have just an enormous wait list at this point.
I don't know if you guys, he's told us the numbers, but it's on the slide in small numbers.
Yeah.
14,809 enrollment, 20,262 on the wait list.
Yeah, it sort of looks analogous to like a Section 8 housing voucher with a waiting list. Do you have any idea if we were to fund the waiting list right now, what that might cost?
The rates for the tiers, they start, I think, at $2,900 a month, and they go up to like, I think it's 7,000. I did a Public Records Act request recently for Los Angeles County, and I think 60% of the Los Angeles County enrollment was in Tier 3 and Tier 4, which is like $3,500 a month up to $4,200, something like that. So, I mean, you could do the math based on those proportions. And I think they produce reports, not regularly, but they're probably findable online. I don't know the entire number, but I don't I hope that helps.
That does help. And I've seen intellectual disability charts based on severity and size of how much people get paid, and it's up to 12 grand a month. And so I don't think a lot of people don't understand how little the behavioral health is with just the taking the SSI maybe, and then maybe getting a blended rate, maybe not. So being able to show what we actually pay for each of those might entice private investment if they had an interest in a specific area. they've been touched by an area and they have sufficient money to embrace, to fund. So without that kind of information, though, it's very hard to, it's sort of hard to act without those kinds of specifics, I think.
No,
Thanks.
I think you're right. And what we notice is that many of the programs I showed on the slide or two ago will reimburse at a decent level. So operators would generally be interested. They just don't even know how to access a contract with many of the delivery systems. And then sometimes they go through all the gymnastics of getting a contract, and the referral level is too low. There is an opportunity. We'll cover it in the I think it's in the opportunity slide to more centralize some of this information so that it's visible more broadly to get more private investment to think about this. But it is just so widely scattered and splintered among different delivery systems that it hardly gets recognition. And again, that's why I'm so thankful for Teresa and her advocacy on this. I think she's raised it to a level where the discussion is a lot more productive at this point.
There's just a quick question in the chat about what's the reason we can't keep up with the demand. And I just wanted to comment that the assisted living waiver requires CMS authority and approval. And so the state of California has actually gone through multiple amendments to continue to add more enrollment, but the cap is set because really because of CMS limitations, right? Because it's federally matched funding through a waiver program. And as you just saw on the last slide, I mean, part of the demand is understanding where all the different programs and delivery systems are to really have a better sense of capacity. Because what we find is that everybody's really kind of within their own delivery system, but we're all sharing assisted living resources to try to meet the needs of the folks that we serve with lots of crossover. And so some of it is just even getting more of a level set on in your county, what does the system look like and who are all those programs and players and delivery systems so that people could be placed at the right level of care and in coordination with everybody else. Yeah.
That's a really good point. When we spoke with the assisted living waiver folks a few months ago, they were pretty clear that their focus was on supporting people transitioning from skilled nursing facilities to a community setting, and then probably also as interested in those who were referred through adult protective services and the ombudsman. So that's where they're prioritizing this. The assisted living waiver was always meant to be budget neutral. So that's sort of how they make it budget neutral, by helping somebody step down from skilled nursing.
Just a quick time check. I think we've got maybe like 10 minutes. Is that right, Teresa? Or is it a little less than that?
I don't have a clock, but just keep going. We're flexible.
All righty. Fantastic. We'll keep going.
All right.
I'm there.
So I think here's some of the challenges. I won't read them to you, but I'll give you some context about what we're talking about. So I think I've mentioned this in a couple of different ways, that access to these beds can be limited by who's actually paying for the bed. Some delivery systems, some counties, for example, may have limits on how many beds that they will fund. Even county behavioral health plans will say, maybe I have capacity to fund 100 beds a year type of thing. And so sometimes that limits a relationship that maybe like a county behavioral health plan might have with an RF or an RCFE or a collection of them in terms of how many they can fund. Sometimes if that operator only has a relationship with the county behavioral health plan, they could have vacant or underutilized beds, or beds that they're only able to access somebody's SSI income. Another challenge that comes up a lot, and it does contribute to why some of the beds are vacant, or underutilized. By underutilized, we mean that the facility is accepting a placement at much less of acuity level than they could actually accept, but they won't accept a higher level of placement many times because the coordination between the facility and the payer, so sometimes it's the behavioral health plan, sometimes it's the managed care plan, isn't great. It's not reliable in many cases, and so they take the position that we'll accept low acuity folks, or that they may not accept all that they could accept from a certain payer type, whether it's housing or county behavioral health. So those are clearly challenges. The reimbursement itself can be insufficient and can be all over the board, as we kind of talk through that one a little bit. In terms of insufficient, it isn't one of those things that you can just make it up by the volume, right? If you're losing money on serving somebody and you accept another person and you're still losing money on it, that's not a good pathway to sustaining your facility or your residents. And so it has been a challenge. There are other payers who could be encouraged to participate more, but it requires the managed care plans, for example, to engage more, which requires the county behavioral health plan and the managed care plans to coordinate. And sometimes that's a problem, getting them to communicate and coordinate in an effective manner. But we kind of rely on that as we utilize resources at this level of the continuum. And I think the last challenge really is around the administrative complexity. For an operator to accept placements from multiple delivery systems, you kind of have to go through the gauntlet, right? You've got to figure out what kind of contract can I sign up for with this delivery system, whether it's the county health system or the mental health system, or whether it's aging or the managed care plans. And then I got to figure out how to get authorization for somebody. How do I get payment? Is it slow? Am I meant to go through a third party to do all this stuff? It can be very, very complex. It's almost like going through a gauntlet. I think in Los Angeles County, I counted up the number of payers that support the safety net, and there's like 15. So, I mean, it's probably an extreme example than the rest of the state, but it's a reflection of what it takes to support somebody with safety net services or Medi-Cal services, and kind of the obstacles that you have to go through.
I want to stop you there on that one, in terms of the administrative complexity, because I think that's huge. Getting operators to get their footing and be able to provide this despite the complexity, since we know that, what did you just say, 15 have done it? So I just wanted to comment on that. And also we have a question in the room, I think. Stacy.
Yes, hi, Stacy Dalgleish, LA County. Thank you very much for being here. I wondered if you're also tracking empty beds that are empty because they've been contracted out but not filled. That's something that we hear about quite a bit on the commission. And the other question I have for you is, do you see that the group that formed of the adult residential facility operators, LARCA, is having any positive impact on the ability for these locations to function better and to stay in business?
Yeah, well, I can tell you that we don't track the beds by, or I haven't seen the beds being tracked by somebody who's purchased the bed and left them vacant. I haven't seen that. And as far as LARCA goes, just out of full disclosure, I do work with LARCA. Both Kerry and I have done work with LARCA in the past, and I work with them quite a bit. They are making an impact in multiple delivery systems by kind of getting the word out that this complexity exists. and also making large delivery systems in both housing and healthcare understand what the complexity is. But I think they're in early stages of implementing a very comprehensive pilot program. It would be worth having them join a commission meeting to give a presentation.
Thank you.
There's a comment in the chat, Ed, that is alluding to just our next slide, kind of along those lines of, is there any attention occurring on how operators can participate in those multiple delivery systems? And is anyone looking at how to streamline that complexity? It's another example of the need for integration coordination. And so I think our next slide kind of highlights some of those suggestions.
Yeah, no, I mean, and you could probably go to the next slide. I think, as Stacy pointed out, LARCA is doing some of that in Los Angeles, where they're creating the awareness of the sort of the spider web that operators have to go through to get to, any number of payers to actually fill beds. Even in places like Los Angeles County, where the county uses an organization that works on behalf of 3 or 4 county entities, they still all have their own requirements. Department of Health Services has a different requirement than the Office of Diversion and Reentry, than does the Department of Mental Health. They all have their own assessment. They all have their own way of reimbursing the provider. They just have one sort of third-party administrator. So even in cases where there have been some amount of standardization, it still doesn't always feel like it to the provider. But we think that there is an opportunity to think about Medi-Cal reimbursement in a more sustainable fashion for communities. I mean, the assisted living waiver clearly is an opportunity that has been oversubscribed, but a lot of what is happening in that waiver is repeatable through the managed care system. It's essentially the same population. The assisted living waiver is really focused on dual eligibles, people who are aged or disabled and who are Medi-Cal beneficiaries. And those are overlaps with the managed care plan population. If you looked at the Venn diagram, a significant number of those individuals would also be people who are enrolled in the behavioral health plans themselves. So there is an opportunity to think about how to sort of sequence which delivery system should get referred to for these services. And I think the other thing to think about when you think about the Behavioral Health Services Act, especially in the new policy, it's very explicit about sequencing payers, right? The Behavioral Health Services Act explicitly states that you really need to leverage all federal financial participants and state entitlement programs prior to using these funds. And so it calls upon the behavioral health plans to do that sequencing. It's an opportunity for boards and commissions to kind of explore that and see if that's happening. We also think another opportunity is to really think about this whole coordination issue. And I won't go into all the bullets underneath it, but I'll tell you, as I was traveling through some adult residential facilities, what I notice is that the coordination between the managed care plans and the behavioral health plans isn't always so great. I see people who are at risk of losing their placement in adult residential facilities, for example, because they have incontinence issues, which means that the coordination between that managed care plan and that person's urologist and an ability to get those, durable medical equipment supplies to support their incontinence doesn't happen. I've seen other places where somebody is needs a bariatric hospital bed. And again, you know, from a placement that's happening on the behavioral health side, they should be coordinating more directly with the managed care, physical health sort of types of plans. And I think those gaps persist throughout many of the visits that I made, especially in Los Angeles County, where the coordination is complicated by the number of participants that are involved in you know, supporting somebody's care. But I think I'll stop there, and I'm concerned that I'm going way over my time, and happy to take more questions.
All right. Yeah. Actually, could you go back to that slide?
Yep.
The last item there, that administrative hubs or intermediaries, to me, that's a huge need for especially for the small facilities, small ARFs and RCFEs. Getting certified on Medi-Cal is no small feat, and then receiving the funding once you bill sometimes can take a long time. So they need that buffer and they need that support. So I just wanted to comment on that.
You know, I think that's a good point, because it's if you do create this administrative hub, this intermediary, you could start with the administrative functions, but you could quickly advance the you know, the benefit of the group to concentrate on quality, right? You could really then get more support around what would support people to remain in place longer in these appropriate settings. And so quality and an ability to focus on performance of improving somebody's conditions or skill plans, care plans, all that could be brought to the table through creating these intermediaries or these hubs.
How far along is LARCA with being able to provide that?
So LARCA, I'm not speaking out of school. This is public information. LARCA was awarded funding through La Casa, which is if anybody's familiar with Measure A in Los Angeles County, it's a funding stream that is generated through a ballot initiative that paid through a sales tax, and they were funded to pilot this concept of you know, creating this hub. So I think the pilot gets awarded in July, and the funding gets awarded in July, and they'll start soon thereafter.
Good news. Okay, thank you.
It'll be on a small scale, but I think it holds a lot of promise.
Good. Okay, thanks. All right, any questions? Oh, yeah, go ahead, Steve.
Could we get a copy of the slides? Because there's,
Yeah.
Thank you.
Yeah, and it looks like you all have questions on the screen here. Are those questions for all of us?
You know, they were questions in case we didn't get any questions. I'm very pleased at the number of questions we've gotten, though. This is great.
I have a comment. This is Adela Cruz with Orange County DHP. So thank you. First of all, thank you for giving us a really good overview of the current industrial complex. You know, and I'm just thinking about in 10 to 20 years, the older adult population is going to be the largest population. And unfortunately, there's a lot of, as you clearly articulated, a lot of health issues, right, that the older population struggles with. So what I heard, and correct me if I'm wrong, so there's two ways of looking at it, right? Are we prepared for what's coming, or preparing for what's coming? Or does the current system have the ability to care for the population? We're just not doing such a great job at allowing our providers to access the funding that will help them, or the infrastructure, or create their infrastructure to help them meet those needs. Am I making sense with what I'm saying?
You make entirely good sense. And I think both, right? We have the infrastructure to do a lot of this work right now. It's the administrative complexity that we've created that, for example, an operator that's trying to support somebody who's aging in place. Let's say that person is in an ARF and they turn 60 or 61 and now they've aged out. Well, they can still remain in that facility as long as the proportion of people who are over 60 are no more than, I think it's 20 or 25%. I can't remember the actual rule, but it still requires coordination with more than one type of entity, right? If we only needed to rely on the behavioral side of the equation, that would be great, because we hear from a lot of operators that they do a great job responding to their needs. It's when they need something from a different delivery system, and you need to coordinate that, and the coordination has to go through the operator and let's use managed care plan or the housing system and the Department of Behavioral Health. All of a sudden, it becomes so complicated, right? It's like, and it's not necessarily standardized. And what we're experiencing right now is all this change in the federal government and focusing on who's eligible for benefits or what benefits are eligible in the new HUD application. All these things create all this turmoil. And I mean, again, this is another plug for this intermediary, right? There's no one going down to the facility level to explain it to them in a way that they can access these delivery systems. And there's no one coordinating these delivery systems to do what you're talking about, help people age in place appropriately. So there is an infrastructure that exists, but it is still riddled with administrative complexity. We also know what we're seeing, and hey, I'm sorry to be so LA specific, but what we're seeing is one of the fastest growing populations of people experiencing homelessness are older adults. And these individuals, many of them are understandable because they have rising risk in a stable environment, and then all of a sudden they don't have housing. So a lot of this is predictable, but again, these systems are completely riddled with administrative complexity and requirements to participate, and I could go on and on and on, but I think there's a big opportunity to reduce the administrative complexity of programming that's serving people in that older adult category.
Hi, I'm Carol Swartzlander.
I put into the mics. Oh, good.
Can you hear me okay?
You're good.
Okay. My name is Carol Swartzlander. I'm the executive director of the California Commission on Aging, and this is a very timely paper to come out for us because just last week we held an informational hearing looking at it was called Addressing the Crisis in Supportive Housing for Older Californians. And what we were looking at are what are the barriers, and especially because older adults are the fastest growing and make up almost half of the homeless the single older adult homeless population is almost half of the single adults population, right? So anyway, we were looking at all of the issues you've been talking about, structural barriers, and we have it on our website. So if you would put ccoa.ca.gov in the chat, okay. The entire the PowerPoint presentation and recording of the entire hearing is right there. So I encourage everyone to go look at it. It's really it is a timely issue. We are going to be doing some more research, and your paper will come into that, and be developing a policy paper and brief that'll come out later this year, making recommendations to the administration and the legislature. So yeah, this is a very hot topic for us. So thank you so much for writing this paper, and I've already sent it to my team. And then I want to share that the Senate we know now that the Assembly and the Senate put out their budget. We have to make revise, but one of the proposals in the legislative budget is called Be Home Soon, and I forwarded it to you, Teresa, to share with everyone. But it is the first time I've seen this kind of investment in HCBS, but it says it takes an all of government, whatever it takes approach to transition older adults and people with disabilities from skilled nursing facilities and hospitals back to the home and the community. They're projecting that it would result in $100 million general fund savings in 26-27 and $600 million ongoing. I have the proposal pulled up.
My understanding, that's in the 11-15 renewal, right? Like that's something that is pending. No, it's not.
No, they literally just put this out like a week or two ago, and I was trying to go to it, but one of the things they propose is eliminating all the wait lists and the cost neutrality for the assisted living waiver. So I did send it to Teresa to share with everyone. I don't know where there's a link online for it, but we'll see what happens with the negotiations. But the fact that the Senate even put this forward was very exciting. I think a lot of things still need to be worked out. I mean, it's a very complex proposal. It has a bunch of different parts, but it's exciting that they did propose it, and maybe some of it will get through in the end.
I think she's.
I would love to see that.
This is not about the CMS waiver. This is about a proposal from the Senate that says we want to eliminate all the wait list.
And are they aligned? CMS waiver?
They just put it forward. So it's not it's not aligned right now because it literally just came out as a proposal.
Hi, this is Steve again. My son was in enhanced board and care for 18 months and it worked out perfectly. But the business model is so broken. And I just want to mention that mixing populations can be very difficult, particularly justice involved in mental health and and ages. Ideally, if you have, it's sort of nice when you have a cross section of ages and people can appreciate each other. But in our county, the Medi part of Cal Optima, our managed healthcare, is 100,000 of the older adults, and so everyone's very concerned about long-term care with older adults because few people have long-term care, and there's a lot of discussions. Helen's online here about shared housing and that thing they do in San Francisco that's pretty successful, and trying to prepare people earlier, like in their families, to take care of them, but to understand the beds that are the beds, and actually not just beds and shared 2 to a room, but bedrooms that exist already built and existing in people's houses, if people would be willing to accept them into their house and then let the system pay through that. So anyway,
it does remind me of an idea that we were trying to organize on another project where, there is some amount of acuity matching or mixing that you need to do. You can't take everybody at a acuity 5 level into one facility. It would just be a very difficult challenge to try to support people in the way that we talked about with ADLs and ADLs. But I think it's something that operators sort of do informally. They try to figure out, well, can I take, I've had a couple just be very blunt, like I can only take 2 people that have meth issues at a time, or I can only take 2 schizophrenics using that kind of.
Wait. I have to say, we do person first language, so I have to stop you there. It's an individual with schizophrenia. That's what we teach. Go ahead.
Yeah, no, sorry about that. I was just using their quotes, but I think that is an opportunity to acuity mix the population to make sure you're not overloading a facility with a certain high acuity type of individual.
Well, thank you so much, Ed and Kerry. Your work is really important, and really appreciate the presentation today. Appreciate the paper. Appreciate the work you've been doing, and I'm just excited to share this information with the boards and commissions, and I'm looking forward to next steps.
Wonderful. Thank you. Thank you so much for having us.